Sorry.
Hi.
Inside voices, be quiet. Hi. Sorry. That's
Are
my
those your friends?
Hello.
Hi. Doing?
Good. Hi.
Hi. How many kids you have there? 3?
How you think to know that?
She doesn't know you. She's saying hi now. Sorry.
You're so cute. It's echoey in there. Are you in your house?
Uh-huh. Can you not hear me?
No, I can. Yeah.
Okay.
I'm not sure if the quiz, have you tried to see if the quiz is open for you, Angela?
It's on the Moodle, right?
Yeah. I don't know if it's open quite yet, or it might not open for another 5 minutes. I'm not sure.
Yeah, it's not ready yet.
Okay, you can just, I think it has to be 12:55.
Okay. What? That's fine. She can draw. Yeah, on the same paper.
I'm
Here.
in class with you.
Do not break it.
Blue pen to fill out shit or black? No matter.
It don't matter.
Does not break it, mister.
What that doing up there?
It's right there on the counter.
No, mister. It's all the same. It's fun here.
Funny shit.
Huh?
Washington with tickets and shit.
Hey, Leslie, you're on mute. Um, is there any way that we would be able to have the Zoom link on Moodle be like a link you can press so you don't have to like go find your email?
Yes, yes, I will do that.
Okay. Okay, thank you.
Mhm. Let me
I
just
was like frantically trying to find your email, like, oh, I need the Zoom link.
where did it go? I'll just post the Zoom link at the top of every week. Just
Okay,
it'll be there.
okay, thank you.
Mhm. So just as you all are coming in, the quiz is in Moodle. It'll open in, I think, 3 minutes. I think it's going to open exactly. In case you're trying and you haven't been able to, we'll open it at 1 o'clock. So the quiz, for those of you who just came in, the quiz should open in just a minute. It should open up at 1 o'clock exactly. And I don't think you're going to be able to see your grade because one of them I have to go in and grade manually. But I can do that pretty quickly after class, and then you should all be able to see your grade by this afternoon. So it should be open now if you guys want to go in and to Moodle and start the quiz. Let me know if you're having any problems. Okay, so I'll go through and check the type-in answers. And so some of you might go up a point just because I have to grade that manually. So I'll do that right after class. I'm going to run a quick poll. I'm going to pull this up because it dawned on me that there's two things that we can do. Before I ask the poll question, there's two things we can do. Some of you might feel like you would rather wait to turn in your study notes until after I've lectured on it, so that you've had every resource in order to answer your study notes. So there's two things you can do. You can write in pencil and you can kind of update it as we go along, but you're familiar with what's on the study notes. You have maybe already tried to look for answers and maybe you feel like you know half the answer, whatever. So you can write in pencil and you can always erase and update after we've gone through lecture. Or you can, if you just can't find the answer and you're like, I just need to wait for class, you can leave it blank and turn it in with some blanks. Because remember, I'm not grading for me for accuracy, it's more like participation. So I just want to see that you've turned it in on time and that you're working at something, learning the material. So with that being said, I'm going to put this poll question up. Would you prefer to hand in study notes Tuesday evening at 9 p.m., so tonight, basically, or keep it the same? So I don't want to make any changes without everybody agreeing to it. I don't really want it to be my change. I want it to be, you guys are like, this isn't working. Can we do something different? I think that's 29:30. Okay. So the majority would rather wait and turn it in like tonight. So basically I know you guys have class after this and brains are probably fried by Tuesday evening, but what I think a good way of approaching that would be start it, read through it, look through the PowerPoints, and then just maybe wait to finish it until after you've heard lecture. So that way you're still on the same kind of path. You just get to hear lecture and then some time this evening, not for today, because obviously the ones for today were obviously due, but in the future, you'll have just a few more hours to kind of finish it up. So starting next week, so then I'll go through all of those study guides, and I will just change the due date from today at 1 to today at 9 p.m. Starting next week. And then I should ask another question, but would you guys like me to change that in the share results? You guys see the results? Would you like me to change that in the course? Or is that something that you want to see actually on the course schedule reflected, or will you just know because you'll click on the due date and you'll see, or you'll click on the submission and you'll see it? Would it be better to actually see that written out on the course schedule? Or some of you might have already printed the course schedule and maybe you can just handwrite it. How does that work best for you guys?
I don't think it would be needed, like, to update the course schedule personally.
Anybody else have a?
I think as long as it's updated in the syllabus or somewhere in handwriting, I think we'll be fine.
Okay, I'll update it, and I will check the syllabus to make sure if it's said in the syllabus one way, I'll make sure to update it there, because that for sure probably needs to be. And then,
Or yeah, Vanessa has a good point. As long as in the submission on Moodle it says
Yeah.
the right time, that would be fine too.
yeah, that I'll have to go through and manually change that one. And so whenever you click on it, it'll remind you when it's due. So I'll change all of those, and then I'll change it in the syllabus, but I'll leave the schedule as is, because roughly it's still the same day, it's just later in the day. But I want to make sure that you guys get it, however you need it best.
Leslie,
Yeah.
I'm curious if we're gonna have time to go over the study notes like in depth and have time for a lecture.
No, probably not. I wish we did. So with that, I'm going to, and I don't want to rush lecture because there's a lot, but I just wanted to say one more thing before we started lecture, is that because I figured you guys are going to want to cover those worksheets and the study notes, I'm pulling up some time in the calendar where I'm just going to have open office hours kind of dedicated to oral medicine. So it's hard to find time for you guys where that fits because of our overlapping schedules, but there's some Monday and Wednesday lunch hours. So I'm going to make a schedule of times that I know that I'm probably available when you are, and I'll have a Zoom link. And then I'll just be sitting at my computer ready for people to pop in and go over stuff. I'm going to try to make it twice in a week, like 1 hour one day and 1 hour another day, so that everybody kind of has an opportunity to, if you can't make one, maybe you can make the other. Maybe I'll try, and maybe I might have to do one an evening, just so I can get some flexibility in the times.
Excuse me, Leslie.
Yeah.
You would be posting the keys anyways, right?
I will be posting the keys. Yes. I actually have them now uploaded in Moodle, but I'll open them right after. I can open them now, or I'll open them after class. Going into the Moodle now. But I want to give some open time where people, or open Zoom office hours where everyone, and that way if a couple of you come in and you have the same question, then we get it answered for multiple people at one time. So I'll post, I started working on it before class, and I'll try and get that up so that you guys, and then I'll send it out to you so that you'll see some times that we can meet up. We can also meet one-on-one, but I feel like if there's going to be a lot of people with a lot of questions, I'd rather have some open office hours where you can all come and get answer your questions. Okay, so I'm opening up the keys here. And you can look at these after class. And then we'll just get to the PowerPoint here and we'll pick up where we left off. Because there is a lot to cover. It is true. Okay. So we left off with that video, this little TED video. Let me get this. Okay, can you guys all see and hear? Okay, so we left off with that video. Remember, it was like that little animation of where you pop the pill and then where it goes. So here we have kind of a diagram of essentially what you saw in that video, where you swallow the pill and it dissolves down into your stomach and it kind of becomes a solution. It might get absorbed in the stomach or it might continue on down into the small intestine, and the medication might get absorbed into the small, through the small intestines into the bloodstream there. So either the stomach or the small intestine, and then into your bloodstream. So once it's in the bloodstream, it's going to start to circulate around your system until it gets to the liver. And then once it gets to the liver, it's going to start the metabolism process. It's going to start to metabolize. So we're going to lose a little bit of that medication once it goes through the liver, because some of it turns to metabolites and kind of takes it out of the body. But what makes it through the liver is going to continue to circulate through the body and kind of do its action, whatever it's meant to do, whether it's a pain medication or an antibiotic or whatever. And then every time it comes back through the liver, more and more of that medication is going to be metabolized and going to be excreted. So now we're going to follow this over to the excretion point, and most of it's excreted through the kidneys, you'll pee it out in your urine. Some medication will be excreted through the large intestines and it'll kind of connect to bile and out with your feces, but most of it out of the kidneys through urine. So this is a very simple stomach, maybe stomach to bloodstream, or more likely down to small intestines to bloodstream, to the liver, gets metabolized. What makes it through the liver is now in the whole circulatory system. Traveling around the body, goes to where the kind of the target site of action is. But every time it passes through the liver, some of that medication is going to get metabolized and then be excreted out through the kidneys. Okay, but how does the medication go from the stomach or the small intestine to the blood, into the bloodstream? So how does it actually get absorbed? So absorption is molecules are transferred from the site of administration in the body to the circulating fluids. So, but how does it actually go through the wall of the stomach? So here we have a little diagram of a blown up figure of a cell membrane. So our cell membranes form barriers that kind of compartmentalize various systems and organs in our bodies. And drugs have to penetrate these barriers to make it into their site of action, wherever it is that they want to go to do whatever that drug is supposed to be doing. They have to penetrate it. So fat soluble drugs, you're going to hear this a lot, fat soluble, lipophilic. Remember, we think of, hydrophilic, it likes water. Well, lipophilic, it likes fat. These drugs can pass passively, easily through this very lipid fatty acid chain, which makes up the cell membrane. So if a drug is more hydrophilic, likes water, it doesn't pass as easily because it can't make it through this lipid barrier, which is pretty much what your cell membrane is mostly, is a lipid barrier. But then you see in this picture, I'm probably pointing to my other screen. So can you guys see my cursor? Can you see my cursor? Okay. So down here we have, this is all the lipid, the majority of your cell membranes made of fatty acid chains. But then you see these big old protein blobs with a little, they call it an ion channel or an aqueous pore. Those are the places where water, hydrophilic stuff can get through. So there's not as many of them. So water, something that's hydrophilic is not going to get through the cell membrane as easily. But lipophilic does. So the medication, if it's lipophilic, it'll just kind of passively percolate through the cell membrane, doesn't take a lot of energy, but it has to be lipophilic. It kind of has to be in that same makeup, or else it's not going to pass through. But it just sort of passively diffuses through the cell membrane.
So do all drugs have to be lipophilic?
Pretty much, yeah. And that is, and so we'll talk about that a little bit more, because absorption or them being lipophilic is affected very much by their pH. So the pH of the environment and the pH of the drug have to kind of match up for the second part of this. So not just this lipophilic part, but this other part, which we'll get to here in just a second. So most drugs, when they're dissolved, they're either a weak acid or a weak base. When you take the pill and it dissolves, it's going to be one of the two. It's going to be either a weak acid or a weak base. So type into the chat if you remember, what would you consider a weak acid? Yep. Hallie's got it there. Anybody else? Yep. I know once you see it once, and I say yes, you're like, you got that's why I tried to do that ready, set, go, but I forget. But yeah, so basically, if we're talking about a weak acid, we're talking about somewhere in the range of 3 to 5 on the pH scale. What about, type into the chat, what about a weak base? Where would you lie somewhere on the pH scale for a weak base? Yes, good. 8 to 10, 8 to 11, I suppose. I've seen it written both ways. So the closer to 1, 2, that's a strong acid. The closer to 12, 13, 14, that is a strong alkaline or base. But most drugs are going to be weak acids or weak bases. So this is going to remind you guys of radiology because we're talking about ionization. But basically, there's a couple things you have to remember. When a drug comes into the body, not only does it have to be lipophilic, but it has to be in a non-ionized form in order for it to be absorbed. So when it is non-ionized, it is just more lipophilic. Don't ask me what starts to happen on a very detailed chemical level. You don't need to know. I don't know. I don't even know. So we don't need to go into the depth of that, but what we do need to know is if a drug is a weak acid and it comes into an environment that is also a weak acid, it's paired up nicely. It likes that environment. It's going to be non-ionized in that environment, and it's going to be more lipid soluble, and then it's going to absorb. So it's just a group of facts that you're going to have to memorize. So down here, we say drugs are present in solution in either their ionized or their non-ionized form. But what we know is that if they are ionized, they're not going to be as lipid soluble, and they're not going to percolate easily through that cell membrane. if they are non-ionized, in their non-ionized form, they will be lipid soluble and they will percolate easily through that cell membrane. We'll keep hitting this. We'll keep hitting this point till this gets, you know, settles nicely. So we know that the pH, how do we know if medication is an acid or a base? I think that we don't need to know. I mean, when you look it up, it'll tell you. When you look up in those books and stuff, there's usually some chemical readout, but we don't need to know that when we have a patient in our chair. That doesn't have any really clinical application for us. It's just so you have the knowledge that this is what's happening in somebody's body. You have the very broad knowledge that this is what's happening in somebody's body, but you don't have to know specifically that, you know, the heart medicine they're taking is an acid or a base. Okay, so the pH is basically the measurement of the hydrogen ions in the concentration of the hydrogen ions. And so like we said before, if it's a weak base, it's somewhere in the 3 to 5, or a weak acid, it's somewhere in the 3 to 5. If it's a weak base, it's somewhere in the 8 to 10 or 8 to 11. And then drugs are absorbed when they're mostly in their non-ionized form. And so that is, again, when the environment, when the drug matches up with the environment, it's going to be more non-ionized. When the drug is more acidic and it comes into a more acidic environment, it's going to like that and it's going to absorb better. If a drug is more basic, it comes into a more basic environment like the small intestines, it's going to like that better, and it's going to be more non-ionized, more lipid soluble, and it'll absorb better into the body. So here's a little diagram that shows it. So aspirin, for example, is a weak acid. So this is an example of a weak acid drug. It comes into the stomach, which is, we know that the stomach is acidic, right? It's an acidic environment. It's very acidic. And so that turns this aspirin solution that's dissolved in your stomach into its non-ionized form. And when it's non-ionized, it is more lipid soluble. And you can see here in the diagram that it's penetrating through the membrane into the plasma. Alternately, if it goes down into the small intestine, which is more basic, it's going to be more ionized and it's not going to absorb as well. Now, this is the theory. This is the pharmacology theory of how it should work. However, things move through the stomach very quickly, and there is not as much space or surface area in the stomach. And there is far more surface area and far more time that something's in the small intestine. So even though in theory, something that's acidic would only want to be absorbed in the stomach and wouldn't want to be absorbed in the small intestine, really a lot more drugs end up being absorbed through the small intestine than the stomach. But that kind of just throws a little bit of a monkey wrench into the nice, neat picture of matching up with its environment. But that's in theory how it does work. When your medication is acidic, it's in an acidic environment, it's non-ionized, absorbs well. Basic environment, non-ionized, absorbs well. But in reality, things go through the stomach relatively quickly and things end up being absorbed in the small intestines more often. It may be a slower absorption, you know, because it's more non-ionized, so it's not going to get through as easily. But you're not going to be quizzed on that. I just wanted you guys to know that because it's just a fact and it's in the textbook, but you're not going to be quizzed on that. It's more important that you remember the weak acids matching up with its environment or the weak base matching up with its environment and how it affects absorption. Any questions there? Okay. Okay, so here we're gonna just do a little review. So drugs, type into the chat. I'm gonna try and keep my chat open here. You can see. So drugs are absorbed into the blood in the blank form. Drugs are absorbed into the blood in what form? How do they get from, let's say, the stomach to the blood? What form do they have to be in? I know we just said it, but it's a mouthful of a concept. Non-ionized, very good. Yes, non-ionized. So drugs are absorbed into the blood in their non-ionized lipid, I'm trying to get my lipid soluble form. So that's the other part that you want to remember, lipid soluble, lipophilic, it's another way of saying it. Okay, next one, highly blank drugs cannot pass lipid membranes. Highly what drugs cannot pass lipid membranes? Yes, ionized. Good job. Next one. Blank drugs can cross lipid membranes freely. Hydrophilic is also right, Lauren. Yep, that's the same. Okay, so blank drugs can cross lipid membranes freely, non-ionized. Yep. Good job. Okay. Okay, here's some more. Blank drugs, this is like repeat, repeat, repeat. Blank drugs are either what or what? Most drugs, sorry. Most drugs are either what or what? Yes. Yes. Most drugs are either a weak acid or a weak base. And how we know? I don't know. We probably can look it up. I just don't feel like I have time to indulge all these curiosities, but look on Lexicon and see if it says it anywhere in the description of the medication. It probably does somewhere. Okay, next one. For blank, the more acidic the environment, the more non-ionized the drug, and the more easily it crosses the lipid membrane. Good, yep. So for weak acids, there we go. For weak acids, the more acidic environment, the happier they are. They're gonna be non-ionized. They're gonna passively percolate through. For weak bases, the more basic the environment, the more blank, and the more easily they're going to cross. For weak bases, the more basic the environment, the more blank, and the more easily they're going to cross. Whenever you think of easy crossing, think of non-ionized lipophilic. Good. Okay, last one. Bases are more highly ionized in a blank environment and not absorbed well. A base is more highly ionized in a what environment? Yes. Very good. Acidic. Good job. It's gonna start rolling in there and you'll be like, okay, I got this. Okay, good job. Okay, so these questions I'll go through. I'm not gonna go through them right now. We'll go through them like first off next class. But when you answer these questions, write it out. Where is a weak acid most ionized? Is that good or bad? Where is a weak base most ionized? Is that good or bad? And then do the same thing for the second one. Where is a weak acid most non-ionized? Is that good or bad? And by good or bad, that means, is it good or bad because is it being, So that's what that means. So answer those questions for next week and we'll hit those next week. But it's pretty much more of the same. Do you guys all feel good about that? Anyone have any questions there yet? Okay, I have no clock anywhere in front of me, so I'm turning on my, so we've been going for, have we been going for 30 minutes already? That can't be possible.
Leslie,
Yes.
so I had a question. Like, why do we need to know if it's ionized or not ionized and like all that stuff? Like, what's...
It's like basic pharmacology knowledge. So you are just learning the most rudimentary understanding of how a medication even gets into the system.
Got it.
That's as deep on that as we're going to get. We're not going to get any, I'm sure there's more to it. I'm sure any pharmacology student has to know more than what we just learned, but that is like your entry level knowledge of how a medication gets absorbed into your system to even start working.
Got you. And am I correct in thinking, so if it's a weak acid or a weak base, that means that it's non-ionized because it's weak, which means it can help cross the lipid bilayer. But if they were like, you know, a strong acid, it makes it more ionized, which means that it's harder for the cells to absorb it because it doesn't like the lipid bilayer.
So it basically just, it's in a form that is able to penetrate it's in its form that's able to penetrate that cell layer when it is non-ionized. And so for whatever, I'm sure there's more to it, but when it's non-ionized, it's also more lipophilic. So because it's non-ionized and more lipophilic during that stage, then it penetrates easily. And then the acid part is that we just know, and again, there's probably more to it, but we don't need to worry about it.
Yeah.
Is that what makes it either non-ionized or ionized is simply has to do with the pH and the environment it's in. So you could take a medication that maybe somebody doesn't absorb well because of something about their body and their pH. So maybe they need a higher dose or something like that. I mean, there's probably further implications that we just don't really need to worry about.
So if it's a weak acid or a weak base, then we assume it's non-ionized.
If it's in its environment where it sort of matches up, because the medication kind of has to match up with the environment to be non-ionized. So
so like if it's a weak acid and it's in the stomach, then we assume it's non-ionized. If it's a weak base and it's in the small intestine, we assume it's non-ionized.
Yes.
But if it was a weak base in the stomach, we would assume it's ionized, and
we assume it's ionized.
Okay.
Yes. And we're kind of assuming it's not going to absorb well and it's going to just pass on through and then it'll be absorbed in the small intestine.
Got it. Okay. That makes so much more sense.
Okay. Awesome. Yay. Okay. I know. Okay. Now we'll talk about, so that's absorption. So now we're going to go on to distribution. So moving around the body. So drugs have an affinity. When you take a drug, and every drug is going to be a little bit different, but when you take a drug, it's going to have an affinity or an attraction for certain proteins in the blood. So now we've moved from the stomach, from the intestine, now the drug is in the bloodstream. Okay, so that's where we're at in the whole scheme of things. We're in the bloodstream. So once a drug gets into the bloodstream, so here we are, here the little tiny dots is the drug. Once the drug gets into the bloodstream, it's either there in a free flowing form, it's just flowing around in the blood, or because it has an affinity for protein, it has found a protein that it likes and it binds with it. So once it's in one of these two stages, if it's free flowing or free floating, it can percolate out through the blood tissue barrier or wall into the surrounding tissue. But if it's bound down to a protein, it's too big and it's just gonna bounce around the inside of the blood vessel and it's not gonna percolate out through. So distribution has a lot to do with how much free drug is able to percolate out of the bloodstream into surrounding tissue, and then how much is bound down to a protein.
So Leslie, if it's on a protein, it's not going to go out.
And if it's on a protein, you can pretty much call it an inactive form of the drug because it's not going to go out.
So then it just gets secreted.
Yeah, it's said in the book that it's that when drugs bind to proteins, they don't bind indefinitely. So that again goes into more detail that we don't necessarily need to spend too much time worrying about. However, it may unbind with a protein at some point, and then it may be able to percolate through the body. But if it binds and then it makes it all the way back to the kidney or to the liver, then it might just metabolize and be excreted.
And then when you say like percolate like through the body, basically it's going from there to like where we need it to go.
Yeah, going out of the bloodstream and into the body where you want it to go. So let's see, I want to make sure I didn't miss anything. Okay, so I'm going to come back to this in a second, but I want to ask you guys a question here. So I know you might not feel like you have enough information to answer these questions, but so if a drug is highly protein bound, if you take a pill that we know is highly protein bound, will it require a higher dose or a lower dose of that drug in order for it to have an effect? Yes, it's going to take more of that drug because it's going to be bound, more of it's going to be bound to the protein, less free floating and able to come out into the tissue and have some kind of effect. Good. So what else can affect protein bound drugs? Can you think of anything else? What other situations might you think about when you think about the fact that drugs have an affinity for protein and can get bound down? What other things would you have to think about in that same ballpark? So I'll give you a hint. Other medications, anything else that you put in your body? Food, yeah, how food might affect that whole system. Supplements, over the counter. Yeah, the patient's just health, overall health, like their like blood conditions or any kind of chronic condition that they have. So I could think one of the main things that I was kind of trying to lead you to, yeah, alcohol. I'm going to go back to this again. Oops, no, here I am. So I'm going to go back to this. So think about a patient who's taking 2 or 3 or 4 or more. I mean, older patients in long-term care facilities can take as many as 10 plus medications. So think about somebody who's taking multiple medications, and what if they are taking medications that have an affinity for the same proteins? So then it's very important that the patient separates doses of certain medications. Now, this is information that doctors and pharmacists have to know and have to be aware of, because if somebody takes a pill that has an affinity for some protein, and then they take a second pill at the same time, basically one right after the other, but one of those drugs has a stronger affinity, but they both like the same protein, but just one beats it out and takes all the proteins and binds itself all up, then you have this other drug that doesn't get any proteins to bind to, the toxicity level has a potential of getting very high and making that patient really sick. So if all of that protein is used up, the other drug has a much higher blood level of that drug. Does that make sense? Did I explain that so it made sense?
So it's like, so there's more free floating of that drug that's not bound to the protein.
Because the other drug beat it out. They both had like the same protein, but one has a stronger affinity, so it took up more of the proteins, and now the other drug is just left floating around, which makes their blood plasma levels of that drug higher and potentially toxic if it's too high, or if they take their next dose and they still have a very high blood level. So that's something to think about. That's something that the prescribing physician and pharmacist, they're supposed to know all that stuff and tell patients, now take this in the morning, take this at night, don't take it with this kind of food, blah, 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 to avoid those kind of potential problems. Okay, I should give you guys a break. Let me just see real quick. Okay, I'm just gonna do metabolism and excretion, and then we'll take a break. And half-life, and then we'll take a break. Three more slides. Okay, metabolism. So the liver uses enzymes to make drugs more hydrophilic. So when a drug goes through the liver and it gets metabolized, it becomes more hydrophilic and ready for excretion. So those metabolites, those drugs that went through the liver that kind of got caught in the liver or changed in the liver, now they're more hydrophilic. They're not going to penetrate as well through the cell membrane and get back into the body, and they're going to be more likely to just be excreted through the urine. So there are certain drugs that can either inhibit or induce an enzyme to do this in the liver. And so it's interesting to note things like grapefruit. This is where food comes into play. So grapefruit juice, you guys might have heard this, if a patient takes grapefruit juice, it can do something to their medication. So the label might say, don't take this medication with grapefruit juice. And that's because grapefruit juice happens to induce these enzymes or inhibit the enzymes that break down a drug. And so the drug will stay in the system much longer. So for example, Xanax is a drug that is prescribed quite often for anxiety. And so if it's taken with grapefruit, it doesn't get broken down in the system and it hangs out, and the levels of Xanax in your system can build and build because you're not going to excrete it as well. So nowadays you can actually see labels sometimes that will say things like, if there's a specific food, don't take this with milk, don't take this with grapefruit, things like that, because it might affect how a drug is metabolized in your system.
Leslie, are you talking about the part in the book where it talks about like the CYP3A4?
Yes. And you don't have to know that stuff.
Okay.
Those are the different enzymes.
Got you. Okay.
Leslie, can I ask one question? I feel really stupid asking this because I feel like I already
No
but,
stupid question.
It can continuously like go through the liver back into like the blood and keeps going through till it's all gone, right? Okay.
Yep, it just keeps cycling through, and we'll talk about half-life here in just a second, which will kind of explain how that can keep happening until it's all gone. So remember, liver for metabolism, kidneys for excretion for the most part. So most drugs leave by way of the kidneys through urine. So we want to, just as a side note, we want to think about patients who have kidney disease. It's going to affect how they get rid of a medication, effectively get rid of a medication. But there's other ways that drugs can get excreted through the lungs, exocrine glands, skin, and then through the intestines. Like I said earlier, in some cases it can bind to bile and then be excreted in the feces, but most generally it's the kidneys. Okay, so half-life, this last slide, then we'll take a break. So half-life, when you take a medication, they determine, every medication is different. It's not just as simple as 2 hours. 2 hours is a nice, neat way to think of something, but it could be 6 hours, it could be 10 hours, it could be, all sorts of different time frames. But what the biologic half-life means is when you took your original dosage, whatever that was, however long it took you to get down to 50% of the original amount that you took is the half-life. And they know the half-life of drugs. Like they know if you take a certain dose of morphine, the half-life of morphine is this, or the half-life of an antibiotic is that. So for example, we use Tylenol here. So if you take the half-life of Tylenol, and the shorthand is T1/2, that means half-life. So if you took 500 milligrams of Tylenol, we know the half-life is 2 hours. So every 2 hours, that percentage is going to reduce by half of whatever you took originally. So if you took 500 milligrams in 2 hours, half will be gone through your system. The half-life is 2 hours for Tylenol. So half of it's going to be metabolized. So you'll be down to 250 running around through your system, just circulating through your system. 2 hours after that, half it again, 125 milligrams circulating through your system. 2 hours later, half it again. So, and it decreases equally over time. Whatever that half-life is, every 2 hours, every 4 hours, every 8 hours, whatever the half-life of the medication is, it goes down by 50% every time that cycles around.
Can you say what you said in the beginning? When you take a medication, something however long it takes
So when you take your original dose and it gets fully absorbed, whatever that original value was, the half-life is when that original value, how long it takes for that original value to reduce by 50%. That's the definition of the half-life. And it's different for every drug. Oh, I keep getting the chat and then it goes away. Yes, so it can definitely affect, Callie, how often you take a medication. Yeah, so that that's why some drugs are, maybe once a day, or every 4 to 6 hours, or once in the morning, once at night, or it could be any kind of instruction on how often to take a drug, and that does have to do with the half-life, because you want your blood level, the plasma level of the drug, to stay at a certain level. And so they know how quickly that drug's going to fall and come out of your system based on, the half-life. And so you keep it up in that therapeutic level by taking a pill every 4 to 6 hours, every 12 hours, once a day, whatever that is. But that has to do also that the half-life comes into play with that.
Hey, Leslie, I have a question.
Yeah.
So I always get confused about the half-life. I just want a little bit of more clarification about the definition. So is it the time, for example, we get 500 milligrams, this is our dose. And then is the half-life after how long half of the dose is going to be absorbed? Does that sound right or no?
Yeah. It's how long it takes the body to reduce that original amount that you took. If it was 500 milligrams or 10 milligrams, how long it takes your body to reduce it or use it up by 50%. That first go through, that's the half-life. And then it's equal over time. Every whatever that half-life is, every 3 hours, every 4 hours, it's going to reduce by half again. But it's original, that first dose, however long it takes it to reduce to 50% from your original value.
Okay, that makes sense. Thank you.
Okay, so let's do, is it always 2 hours? No, so it can be all different times. Half-lives for different drugs are always different. So it's not always just 2 hours. Okay.
If you were to ask this on an exam or quiz, would you give us the time increments? This drug is half-life is good for 2 hours, or how do we figure out what the half-life is?
I think that you'll either get, I haven't looked super far ahead into some of the, you know, like the final, like the comprehensive. So I don't know how it's always been asked, but you will probably either get, you'll get some information so you know how to make the, and I don't even know really how complex you'll get for a half-life question, but you do want to know the general definition of it, what it means. And then you'd probably end up getting some information, like you'd either be told what the half-life is, like the half-life of a drug is every, you know, 4 hours, or, you know, half-life is 4 hours. So you'd be told some key information to help you figure out whatever the question is. It wouldn't just leave you without, you'd probably be told at least what the half-life is. Okay, let's take a break. We have 15 minutes. Oh my gosh, you guys. Okay, let's take a 10-minute break and then come back. And that's probably gonna be the only break. I'm so sorry. I wanna put more breaks in, but there's just so much information to go over. So 10 past.
Hey, Leslie.
Yeah.
Little question before we start.
Mhm.
When the drug, before it gets into the body, is it considered ionized?
Before it even gets into our body, like when it's still in the pill form?
Yeah.
Oh my gosh, that's a really great question. I have no idea.
It's ionized before it gets non-ionized.
I think when we have the pharmacology faculty come, I think we should ask them that question. Hold on just a sec, you guys. Okay, just got, I'm gonna pause. That was Amy. She asked me to do something really fast for you guys to do. I'm sorry. Okay, now I'm recording. Pause, record. Yeah, I think I'm recording now. Before it had like a little sign up in the corner where it says recording, and I don't have that sign anymore.
I see it on our end.
Okay, sorry, that little bit was not recorded. Okay, I'm gonna spend very little time on this because I just really need to, I mean, holy crap, I need to go fast. The FDA right now uses this pregnancy categories where they kind of have I can't even think of the word I was gonna use, but broken it up into categories for safety for a fetus or a developing fetus. They are in the middle of changing this. You still will find drugs that label with the category A, B, C, D, E, D, and X, but the FDA is phasing this out, and they're making just very specific labels that say what the risks are, more information about the risks to the fetus, instead of just simply saying category A, category D. And so it is something that you're not going to see these categories in the coming years, but it takes a long time for this change to happen. So it's important for you to look over these, look at the the risks for the different, especially the ones that are absolutely probably contraindicated. And be familiar with kind of the verbiage of it, but just knowing that it is going to change. These are going to change and they're kind of being phased out. Okay, drug interactions. So adverse or toxic side effects when certain drugs are given concurrently with another drug or an herbal supplement or food. So example, tetracycline, when taken with milk, it basically binds it up and it doesn't let your body absorb it, and the medication becomes ineffective. So, critical thinking question, are drug interactions an example of an adverse drug event, or are they an example of an adverse drug reaction? I'm going to give you guys, anyone else want to answer? Okay, so if we think of the example of the tetracycline with the milk, it's actually an adverse drug event because if somebody, say the doctor doesn't bother to tell them, they're taking tetracycline for some infection or something, and they don't bother to tell them to not take it with milk or dairy products. And every single time they take that medication, they take it with milk, and then it binds it all up and it never does what it's supposed to do. And now they're getting worse, they're getting sicker. Something really bad happens because the antibiotic didn't kick in and do its job. So it's actually more of an adverse drug event because it would have been predictable and preventable, right? Do you guys see that?
But I guess I'm overthinking it, but like, wouldn't that be on the bottle?
It should be. So that would be something where if it would have been a mistake, whereas if they didn't put it on the bottle or the doctor didn't mention it to the patient, something like that. But you're right. I mean, it should be on the bottle and those instructions should be very clear so that that kind of a thing doesn't happen. But if it does happen, then it's an adverse drug event. Okay. Pharmacotherapeutics. We just got a few more slides. We're gonna blaze through this because this is all, I feel like this is not as sciencey and a little bit easier to understand. Your drug dose is just simply the quantity of drug that you're taking, 5 milligrams, 500 milligrams. It's just the quantity of drug. Your loading dose, these are important terms for you guys to know. So do memorize these terminology, but your loading dose is a big dose that you're going to take right out the gate that's going to raise up your therapeutic level of the drug in your blood. It's going to raise it up to an area where it can actually start to have a therapeutic effect quickly. So you're going to take a large dose right out the gate. That's your loading dose. And then your maintenance dose is a lower dose that you're going to take every 4 hours, every 6 hours, whatever the prescription is. And it's a lower dose to keep you up at that therapeutic level. So a loading dose is just one initial big dose of the drug to get you rapidly up to that therapeutic level in your blood. And then the maintenance dose keeps you up there. Therapeutic versus toxicity. There's a fine line. You don't want too little drug. You don't want too much drug. If you don't have enough drug, you're not going to have a therapeutic effect. If you have too much drug, you get sick, you could die, something bad could happen. So we have a couple terms here that you need to know. Minimum effective concentration. That is the minimum amount of drug you could take and it still works. Minimum effective concentration. The smallest amount of drug that you could take and you'd still get some kind of a therapeutic effect. Then you have the toxic concentration. That's like you went past the therapeutic effect of the drug and into, now it's going to make you sick. It's going to do something not desirable. So that's too much of the medication, the level of drug, which will produce a serious adverse effect. And then you have the therapeutic range. So then you have the sweet spot, somewhere in between that it's enough to give you a therapeutic effect. It's less than the amount to cause some kind of toxic reaction. So here's some things that will, I think the next slide shows in the picture. So here we have, this is your therapeutic range. So this is the area that we want to hang out with when we are taking a medication. But as you can see, it takes you a little while to get there. So these are 2-hour increments. So it takes 2 hours for that medication to rise up in the bloodstream and get to the minimum effective dose and then into the therapeutic range. We have our toxic concentration up here. So we don't want to ever hit that. We don't want to hit the toxic concentration. But then the blood level of the drug is going to peak at some point, and then it's going to start to come down. And that's about when you'd start to take your next pill, so it can keep the amount of drug in your blood high enough to cause a therapeutic effect. But you can see it takes about 2 hours to start working, and then it's only actually working if you only took that one pill for 2, 4, 6 hours, and then it drops below the minimum effective concentration. And even though the medication is still in your system, it's not being very therapeutic. It's not really doing much. It kind of drops out. So, but this is that therapeutic range where you want your medication to kind of hang out. So here we see another picture that shows an example of the loading dose. We have the loading dose, a big 40 milligrams or whatever this is, of whatever this drug is, that they take, and then they take these smaller maintenance doses, keeping them in the therapeutic range. Or patient B, or whatever, took this drug, and they just took this same dose every 12 hours, but it took them 48 hours practically to get into the therapeutic range. So this person got into the therapeutic range in just a couple, 12 hours because they took a loading dose. This person took a couple days to get into the therapeutic range because they did not take a loading dose. Do you guys see that? And then a few more terms. Potency is just the dose or the amount of drug required to produce a particular effect. So, 1 milligram of some drug could cause an effect, or 100 milligrams of a different drug can cause an effect. So that's the potency. Some drugs are very, very potent and need a very small dose. Others aren't very potent and need a big dose. So the potency will be different for every drug. And then efficacy is the ability to produce a therapeutic effect regardless of the dose. So how efficacious or how much efficacy does this certain drug have? How easily is a therapeutic effect able to happen, even depending on the dose. So when they talk about a drug's potency and efficacy, that's usually what they're talking about how successful a drug is. Did they get therapeutic effects based on the dose, or how I want to say efficacious. I don't even know if I'm using that word right, but depending on its efficacy. So those are the two things that they talk about when they talk about how successful a drug is.
Hey, Leslie, what's an example of efficacy again?
Say it again.
Oh, what's an example of efficacy again?
Efficacy, well, it's basically the ability for it to have a therapeutic effect. So if you take something, let's talk, here's a good example that you guys might have even had this. So when we talk about a mouthwash having efficacy, we might say scope doesn't have very much efficacy. I hope I'm using the words right. Doesn't have very much efficacy because you rinse with it and you spit it out and really nothing has happened to the bacteria. So it's not very, I want to say efficacious. I don't know if I'm making that word up. It sounds right in my head.
It's not like as effective no matter
It's not as effective, Whereas if you rinse with chlorhexidine, have you guys been introduced to chlorhexidine yet? I don't know if I see any head shakes. If you rinse with chlorhexidine, it will keep working in the mouth after you spit it out. So it has a higher efficacy, whatever. I'm not explaining it as good as I want to explain it, but that is a good example. Like, so patients say, can I just use scope? Well, you rinse with it and it might do a little something, but you spit it out, it stops working. It really has it's not very effective. Whereas chlorhexidine it keeps working even after you spit it out, killing bacteria. So that's why when they talk about potency and efficacy, that's kind of why they describe how well something works. This shows potency pretty good because it shows how this opioid, the hydromorphone, you could take 1 milligram of it and it is just as effective as 10 milligrams of morphine or 100 milligrams of codeine. They all work the same, but this hydromorphone is very potent. Morphine is like somewhere in the middle, and codeine is not as potent. And then aspirin is the least potent of all of them. So that's just what that's showing, is that different drugs have different potency. But they all are going to hit a ceiling effect or a therapeutic ceiling effect where you're not going to get any more therapeutic benefit just because you take more of the drug. So you could take more of it and you're not going to have more pain control. You're just going to possibly have some negative side effects. So most drugs have what they call like a ceiling, basically a ceiling effect, where you're going to only get so much benefit, therapeutic benefit, and then you hit the ceiling. Okay. I'm going to grab the other PowerPoint slide very quickly. Okay, I know we need a break, but we are almost done, right? We only have like 10 minutes. So I am going to get us going on this. We will not finish it. And I'm going to send you guys out a couple times that we could meet and talk about some of this stuff. But let me just get us started on a few of the slides. Okay. So we're going to talk about kind of a complex system that I'm hoping we can break down and have it not feel so complex after we talk about this enough. Okay. So a lot of you probably maybe will think that some of this sounds familiar from some other science courses you've taken in, your schooling time in school. And some of you might have been like, yeah, I know we might have talked about it, but I just don't remember anything about it. So and some of you might be somewhere in between. But the nervous system, when we talk about the nervous system, we're dividing it into two major sections: the central nervous system, which is basically your brain and your spinal cord. So that's your central nervous system. And then we're going to divide it into the other section, which is your peripheral nervous system. Your peripheral nervous system is basically, think of it as the periphery. It's all everything outside of your brain and your spinal cord, and it's the way your brain talks to the rest of your body. The peripheral nervous system is divided into two major parts. And that is, oops, I already jumped ahead of my notes, and is divided into two systems. And that is the somatic nervous system, which is voluntary. So that's, I'm going to raise my arm and wave. That's voluntary. We're not going to talk about that. And then, but what we are going to talk about is the other section, which is the autonomic nervous system. That's involuntary. The autonomic nervous system is further divided. Everything just keeps getting divided and divided. The autonomic nervous system is further divided into two areas, the parasympathetic division and the sympathetic division. So you can see that here. So here's the somatic over here, voluntary. We're not going to worry about that. The autonomic divided into parasympathetic and sympathetic division. So as we go down the line, you can see that in the parasympathetic system, we have predominantly, we were talking about receptors before. Remember, we were talking about those receptors that catch drugs or they catch neurotransmitters or hormones. So these are some of those receptors. So in the parasympathetic division, we have what's called cholinergic receptors. Cholinergic receptors. And the cholinergic receptors are either a muscarinic receptor or a nicotinic receptor. So muscarinic receptor and nicotinic receptor are both cholinergic receptors in the parasympathetic division. In the sympathetic division, we have adrenergic receptors, and those adrenergic receptors are alpha receptors and beta receptors. Let me see if I forgot anything in my notes. Okay. So
Leslie, the cholinergic are only in the parasympathetic and the adrenergic are only in the sympathetic.
Yes. So I'm going to just keep saying it, but it's really important for you to pair cholinergic with parasympathetic, adrenergic with sympathetic. Just highlight that, pair those together. And then,
Sorry, am I correct in thinking, so adrenergic, or however you say it, that's the adrenal gland, which is your sympathetic division, which has the norepinephrine and the epinephrine?
Yes, and we'll talk more about, because that is also things to add to it. We're kind of going to build on it.
Okay, and the adrenal gland is the one that has the alpha and beta cells in it, correct?
Yeah, although we kind of go into explaining it a little bit from a different.
Yeah. I'm just trying to think of a way to like remember it, and if that helps me, maybe it can help me.
I think it's not so much in this PowerPoint, that's not the angle specifically that we come from. So I don't want to confuse anybody, but you are right, Callie. That is a good way of thinking about it. Okay, so the autonomic nervous system is when involuntary nerve cells transmit impulses to smooth muscles and make things happen in the body. So that's the autonomic nervous system. It's transmitting signals, it's talking to these areas to smooth muscles, and then some reaction happens, something happens. So we have two phrases that we use to kind of sum this up. The first phrase for the parasympathetic division is rest and digest. And when we are in rest and digest, we have things happen with our body, like our pupils constrict and we can we focus into what's up close. We're not so worried about what's out there, far away. So our pupils constrict, our saliva stimulated, we're relaxed, we have lots of saliva flow, our heart rate is relaxed, we're not stressed out. Our breathing, it's constricted, it makes it sound, that actually sounds uncomfortable to me, but think about it as you're not in high oxygen demand. So your breathing is, doesn't have to be like these big gasps. So your breathing is restricted and you're digesting your food, you're relaxed, your digestion is stimulated. The other phrase for sympathetic division is fight or flight. And that's the one we're all kind of used to hearing about because we all live in kind of this constant state of anxiety. So we're all in this fight or flight when we're nervous about an exam or when we're nervous about whether or not our family members are going to get sick from a global pandemic or, any of these things, not just if we're, running away from a beast or something like that, like our ancestors had to. But so when you're in sympathetic, your pupils dilate so you can see far off so that you can focus far off and away. Your mouth dries up, your heart rate increases, your breathing is faster and deeper and bigger, and you don't need to digest your lunch anymore. That can happen later after the crisis is over. So digestion is inhibited. Here is something that you guys should look over pretty carefully. This is a nice visual. The parasympathetic comes out. These are neurons. We'll get more into this, but these little projections are basically pictures of neurons. And the neurons come out of the brain stem and the sacral part of the spinal cord for the parasympathetic. And then they come out of the thoracic and the lumbar for the sympathetic. But then just kind of read through these, see the image. These are good for you visual learners. It says, constrict the pupil, stimulate salivation. This is when you're in rest and digest, and on, all the different organs that are activated. And then the ones that are shut off, or this little thing up on top of the kidneys is the adrenal medulla. I think I'm getting that maybe wrong, but it's not specifically pointing to the kidney here. It's pointing to the gland on top, the adrenal gland on top of the kidney. But so just read through that. That will kind of help you remember the different things that are kind of generally divided in the parasympathetic and the sympathetic division. Sorry, I keep using my cursor on the wrong one. You guys are down here and I keep going up to my bigger screen. Okay, so I want to, how much do you wear? 3 minutes. Okay. This might be the last slide I get to. So we want to start with the basics. We want to start talking about how this communication or this action potential goes from your brain to the rest of your body. So the central nervous system talks to your body through neurons. So we're looking at a picture, we're looking at neurons here in this schematic. So that's how these messages get out, through neurons. You can think of a neuron as, hopefully this helps some people, but you can think of a neuron kind of as like an electrical cord, that plugs in, like the wall is the central nervous system. The wall is like the brain. And then the cord that goes to the lamp is the neuron. And then your lamp can be like your heart or something. So that cord is what's going to help get that message. It's the neuron. It's going to get the message from the central nervous system to the organ. But a cord, but the neurons are not just one long thing. They're segmented into pieces. So you can think of your cord has like, 2 segments. And then those segments have to communicate somehow because they're not actually physically touching. They're just hanging out really close to each other. So how do those neurons or those segments of our cord communicate? Well, they communicate with neurotransmitters. So here's our brain. This is our central nervous system. This is one neuron. And then this is showing some neurotransmitters that are going to help this message jump to the next neuron and then on to the target tissue. So why are they called preganglionic and postganglionic? They're called that because these little areas where the segments come together, one segment and the next segment, or one neuron and the next neuron, that little area is called a ganglion. So this is a ganglion right here. And so that's why a preganglionic neuron is the one that goes from the central nervous system to the first ganglion. And then the neurotransmitters come out and they tell a message to the next neuron. And then the action potential is sent down that neuron until you get to the next synapse. You guys have probably also heard this term, a synapsis. So that's what's happening inside of a ganglion, a synapsis is happening. And so the neurotransmitters are hopping over here, sending a message, and then that is sending down an action potential until it gets to the next synapsis where more neurotransmitters come out and attach to some receptors in the target tissue, or in our little example, in the lamp that sends that message to the lamp to turn on and light up and have the light come out. So what is a neurotransmitter then? A neurotransmitter, these little triangles, is a chemical substance that's actually made in the neuron, and it is released when there's something that's supposed to happen, your body's supposed to do something to make some action potential happen. And it's basically that communication. It's the part that actually helps the body communicate and send that message to whatever the target organ is, whether it's the lungs or the heart or the eyes or the bladder, whatever it is. So if we zoom in,
Leslie, I know that
are we over? We're over.
we're over.
Okay.
Can I just ask you one question?
Mm-hmm.
So if you're in the autonomic nervous system, is it always going to be a postganglion neuron? And if you're in the CNS, it's always a preganglion neuron?
So coming directly off the CNS, it's always preganglionic.
Mm-hmm.
The next neuron after you've hit that first synapses area in the ganglion is always called the postganglionic neuron.
Okay.
And we'll talk a little bit, we'll hit that pretty good.
And that's in your ANS technically, or your PNS.
Oh, you mean the peripheral? Like, are you in the periphery now? Is that what you're thinking of? Like once you're in the ganglionic? I think you're even this first, I think once you hit this first ganglion, you could call that the periphery.
Okay. And then depending on if it's, autonomic or somatic or whatever.
Mm-hmm.
Okay.
And then whether it's parasympathetic or sympathetic is going to have, it's going to change with the neurotransmitters that are there and the receptors. And we'll talk, that's what we'll talk about next.
Okay.
Okay. So we'll end here, and I'm going to send you guys out an email with some dates, some times that we can, we won't go over this just in case not everyone can make it. We'll start next week with this. But if people want to talk about the handouts and the study guides and all of that stuff, I'll post some times when we can do that. Okay.
Leslie, we can't, like, are we going to be behind in lecture like at all? Like record this and we can just like.
I will. Yes, I'll keep going. What a great idea. Who said that?
I did.
I'm gonna keep lecturing and then post the whole lecture. And then there'll be times when you guys can meet up for clarifying questions. That's what we're gonna do. I'm gonna keep going, and you guys can go.
Thanks, Leslie.
Thank you. Oh, I'm so glad someone said. Okay. So here we are then. Let me go to the next slide. So here we are, we have zoomed in to a synapses area. This is called a synaptic cleft. You can see it's kind of like a concave, and this is where the neurotransmitters leave the neuron. So they're produced inside the neuron, and then they go over here to the other side. This is zoomed into a ganglion or a synapses. They go over, they attach to the receptor, and then they tell their message and they get that action potential, and it keeps going down the line. So neurotransmitter reaches the receptors to regenerate an action potential. So this is inside of a ganglion, basically. So this is just revisiting this, this picture again. Now that you can see each one of these here, oops, sorry, pointing to the wrong area. Each one of these here is basically like an image of a neuron, although you just can't see, they don't put in the ganglion. But so it's not just one, it's divided into two, but you can see this is where the neuron comes out of the brainstem that affects the eyes, it affects the salivary glands and so forth. But that's basically what those are showing, our ganglion. Or neurons, sorry. Neurons. Okay, so there are two types of neurotransmitters, major ones that we're going to talk about. There are other ones, but the two primary, and this is important, star this or highlight this, but the two primary kinds of neurotransmitters that we'll be focusing on is acetylcholine, ACH for short, and norepinephrine, NE. Those are the primary neurotransmitters that we're going to focus on. There are other transmitters. Epinephrine we'll talk about sometimes, but we won't talk about it as much for sure as acetylcholine and norepinephrine. And then dopamine, serotonin, and GABA, those are all also neurotransmitters, but they are not going to be mentioned as much. So we are going to focus on the primary neurotransmitters. Again, star this. You want to know this for an exam, acetylcholine and norepinephrine. So here we go with this nervous system drawing again, and it's the same as the one that was in the beginning, although I actually think the sympathetic and the parasympathetic have been reversed, but other than that, it's the same flow, except for I added the neurotransmitters. So we have in the sympathetic division, you're going to have acetylcholine and norepinephrine. And in the parasympathetic, you are only going to have acetylcholine. So you want to star that, highlight that, remember that. So in the sympathetic division, the neurotransmitters acetylcholine and norepinephrine are going to bind with alpha and beta receptors. Those are our adrenergic receptors. And in the parasympathetic division, acetylcholine is going to bind with muscarinic and nicotinic cholinergic receptors. All right, so the cholinergic receptors are muscarinic, which is it innervates sweat glands and blood vessels and smooth muscles, and it slows cardiac function. Those are some major points of what muscarinic receptors do. Then we have nicotinic receptors that cause skeletal muscles to contract. The neurotransmitter acetylcholine is released from the parasympathetic preganglionic and postganglionic nerves. And I'll show you this in a picture that'll help the visual learners a little bit better. So when you think cholinergic, think parasympathetic, pair those two in your mind. So what catches, and then when we think about what's catching the neurotransmitters, it's the receptors, it's the cholinergic receptors, it's the muscarinic, and it's the nicotinic receptors. So that's what's catching or binding with the neurotransmitter. So here's a pretty awful picture that I drew on a computer program. So I didn't draw it by freehand, but this here, this little imagery up here this is a spinal cord, supposed to be a spinal cord. And then this is a neuron coming off of the spinal cord, and this is a first ganglion. And then this is the next neuron. So this is the postganglionic neuron. And then this is the next area where the neurotransmitter will bind with receptors on the target organ, which in this case is the heart. So then I took this ganglion, this little happening here, whatever's happening here, I blew it up, and now we can see this little synaptic reaction. We can see it bigger. So now we have the preganglionic neuron, which would be this guy here. This is the preganglionic neuron releasing acetylcholine. This is releasing acetylcholine. And we have nicotinic receptors on the postganglionic neuron. We have nicotinic receptors waiting to bind with that acetylcholine. It's going to send that message down through this neuron till it hits this next little synapses area on the target tissue. So then we have the post, so then this little area in red is blown up to this image over here. We have the postganglionic neuron, that's this guy here. And with a parasympathetic division, we are going to release acetylcholine at the post ganglionic neuron and the pre. So just like it said here, neurotransmitter, acetylcholine is released in the parasympathetic, preganglionic, preganglionic and postganglionic nerves. And that's what it's showing here. Here's our preganglionic neuron, comes from the spinal cord to the first ganglion, releases acetylcholine. And then we have the postganglionic neuron over here, coming to the target organ, releasing acetylcholine. Both places, acetylcholine is the neurotransmitter that's released. This time though, on the target organ, which is our heart in this case, we have muscarinic receptors. So in this one over here on the postganglionic, we had nicotinic receptors, but now on this target organ, which is in the case with most target organs, they're muscarinic receptors. I know this is a lot. Just keep looking, watch videos too, Google this and watch a couple different people explain this, and it becomes clearer and clearer the more you can just think this process through. Draw it out, draw your own image of it. That helps as well. Okay, so now the sympathetic division. So we have the adrenergic receptors. So in the parasympathetic, we have the cholinergic, muscarinic, nicotinic. In the sympathetic, we have the adrenergic receptors, alpha and beta. Alpha and beta are subdivided into alpha 1, beta 1, beta 1, beta 2. There is a beta 3, but it has more to do with like lipid fatty tissues or something, receptors on fatty tissues. And there's not a lot of drugs that utilize that. So we don't really learn about it. So we're mostly just focusing on alpha 1, alpha 2, beta 1, beta 2 receptors. Neurotransmitters. Acetylcholine is released from all preganglionic neurons. Norepinephrine, this is the difference. Norepinephrine is released from most postganglionic neurons, which then crosses the synapse and has an effect on the tissue or the organ. And epinephrine can also be released as well. But remember, our primary neurotransmitters is acetylcholine and norepinephrine. So here's a little drawing again, the same ugly old little drawing, but with a couple little differences. So we still have the spinal cord, this first neuron, the first ganglion, the second neuron, the target organ, which is the heart. So the same setup as when I called it the parasympathetic, but now it's the sympathetic because why? There's a few changes. We have our preganglionic neuron that's releasing acetylcholine to nicotinic receptors. That's the same as with the parasympathetic. And then we have our postganglionic neuron. And then over here, when we are leaving our postganglionic neuron and showing the synapses between the postganglionic and the target, instead of acetylcholine being released, we have what we call catecholamines. And catecholamines are the neurotransmitters with the sympathetic, and they are things like norepinephrine, epinephrine, dopamine, serotonin. But remember, our primary neurotransmitters that we're going to talk about is norepinephrine. So in case you see that word catecholamine and you're like, what the heck is that? Where did they talk about that? That is basically just a phrase for the neurotransmitters over here on this side of the sympathetic nervous system. So it's your norepinephrine, your neurotransmitters in the sympathetic nervous system, norepinephrine, epinephrine, and then the other ones, GABA, serotonin. So the postganglionic neuron is going to release its norepinephrine because we're going to say that's what it's doing because that's our primary one that we talk about. And it's going to connect with receptors down here that are your adrenergic, alpha 1, alpha 2, beta 1, beta 2. So that's the main difference. What's happening on the postganglionic and the target tissue is very different in the sympathetic nervous system than the parasympathetic nervous system. That's where the big difference happens. Okay, so adrenergic receptors. So different tissue has different receptors with which the sympathetic neurotransmitters may interact. With the alpha adrenergic receptors, they're subdivided into 1 and 2. So alpha 1 adrenergic receptors are located on smooth muscle tissue, produces smooth muscle contraction, blood vessels contract, sweat glands, eyes, intestines, smooth muscle contraction. Alpha 2 is located on the post-ganglionic neurons. It inhibits, so I'm going to look back over here, down in here. It inhibits the release of the norepinephrine, having a tendency to decrease blood pressure, decrease secretion of insulin. So alpha 2. You're going to start to see that there's some receptors that tend to be used more for drugs. They're just more therapeutically effective for things that we need them for. And then there's some things that you're not going to, that's very rare, like it's not a common drug at all. And it just doesn't do, you know, like, it just doesn't, it's not utilized very often. So we don't see like an alpha 2 blocker or something like that. I'm just saying it randomly because it's just not used as often. Okay. And then beta adrenergic receptors, when we, again, I'm just to remind you guys, when you think adrenergic, think sympathetic. So just have this word pop into your brain as sympathetic receptors. So the beta adrenergic receptors are divided into predominantly 2. There is a third, like I said, that has to do with fatty tissue receptors in fatty tissue, but we don't really study that. So, but to help you remember, there's a couple different ways to help you remember. Beta 1 is located in the cardiac tissue. It increases heart rate and contractility. Beta 2 is located in the bronchi. It also relaxes the uterine and vascular smooth muscle. So you can either remember it mnemonically, like you have 1 heart and 2 lungs, beta 1, heart, beta 2, lungs, you have 2 lungs. Or another little trick you could think of is you have 1 beating heart, 1 beta beating heart, beta 1. I don't know if you guys, I have no faces to see if that generated any recognition, but beta, you have 1 beating heart. Anyways, but you can also think it mnemonically as well. That might be easier. Okay. So now, if you remember when we just talked a little bit ago about agonists and antagonists, so now we're going to talk just a little bit about autonomic drugs. So autonomic drugs work by acting on either an agonist, remember that causes an effect, that is, they are highly effective, they latch onto a receptor and they stimulate something to happen. Or alternatively, a drug can act as an antagonist or a blocker. A drug can act as an antagonist and block a neurotransmitter or a hormone in the body from doing whatever it is that neurotransmitter or that hormone wants to do. These drugs that are either agonists or antagonists work both in the cholinergic and in the adrenergic receptors. So agonists and antagonists work in both places. They work in the parasympathetic and the sympathetic nervous systems. So here we have agonist drugs that bind with a receptor, they produce an effect. Antagonist drugs that bind with a receptor and block the results of an agonist or a potential or to produce a result. Some more details here. Agonist substance, which initiates a physiological response when it's combined with a receptor. It's a drug which initiates the action of the neurotransmitter, and it produces an action or a response. So just think action, make stuff happen. Antagonist, substance which interferes with or inhibits a physiological action of another, is a drug that blocks the neurotransmitter so it can't do its thing, or it produces an opposite action or response. Here's that same slide we saw earlier. Here's your receptor. Here's the endogenous substance, like your neurotransmitter or your hormone, being taken up into the receptor site and causing its body action. Here's the drug acting as an agonist, stimulating something. Here's your antagonist acting as a blocker and not letting your body be affected by a neurotransmitter or a hormone. Okay, so drugs that are cholinergic agonists. So if it's a cholinergic agonist, it's a drug that causes an action in the parasympathetic system. And they have an affinity for muscarinic or nicotinic receptors. So a cholinergic agonist drug has an affinity for the cholinergic receptors, the muscarinic and the nicotinic. Preferably muscarinic. Usually it's a muscarinic affinity because those are typically on the target organ or the target tissue, the lungs, the heart, whatever it is that medication wants to go do. It's usually muscarinic receptors. Cholinergic agonists can slow the heart rate, relax the GI and the urinary tract. Then there's natural plant alkaloids that are cholinergic agents as well. And that would be muscarine, which is actually a mushroom that's actually a poisonous mushroom. That's where you get the name muscarinic. It's named that because of the muscarine mushroom. Nicotine, we all know nicotine is in tobacco. So that's where the nicotinic receptor is named for, is after nicotine. And then there is another thing called, I'm really bad at pronouncing this one, pilocarpine or pilocarpine, which is used to treat xerostomia or dry mouth. So that is a cholinergic agonist, which helps with dry mouth, helps to produce more saliva. So these are cholinergic agents that there's also cholinergic agents that treat myasthenia gravis, which is an autoimmune, kind of a neurological autoimmune disease. It helps stimulate acetylcholine production. And then there's also cholinergic agonist drugs that help with Alzheimer's disease. Anticholinergic drugs, or they'd be blockers, anticholinergic drugs block both the muscarinic and the nicotinic receptors. So they're blocking these receptors. They're blocking the muscarinic and the nicotinic receptors. They're mostly used to decrease heart rate, treat urine incontinence, and motion sickness and IBS. Irritable bowel syndrome is IBS. So those are the ones that block the muscarinic and the nicotinic. Kind of think of like the opposite of what the parasympathetic nervous system does. If you're blocking it, you're going to get kind of opposite reactions. So you're digesting and your GI is going when you're resting and digesting. But if you have irritable bowel syndrome, maybe you need that to be a little bit less active. And so then you might be taking a cholinergic antagonist drug or an anticholinergic receptor drug. Okay, so sympathetic nervous system. So the alpha blockers are primarily used to treat hypertension. So if somebody, sympathetic nervous system has to do with, if your heart rate is increased, that sort of thing. Maybe your your cardiac output is high. So then you might need to block that and reduce blood pressure. So alpha blockers are primarily used to treat hypertension. So as clinicians, we have to be aware of patients who are on an alpha blocker and orthostatic hypotension, or low blood pressure. If they get up too soon and their head gets light and they get dizzy, they just need a second to kind of I always say you got to recalibrate. Sit them up slowly and let them recalibrate before they get up so they don't get up too fast and fall over and get dizzy. Beta blockers are also primarily used to treat hypertension as well. So adrenergic agonists, we also call them sympathomimetic drugs. They stimulate receptors in the sympathetic or adrenergic nervous system. So they stimulate some of those already. We kind of think of, you know, things in the sympathetic as kind of already stimulated sometimes. Like we might think of, you know, like our heart rate's already going fast and our breathing might already be big, but they stimulate some other things that might have been suppressed that get turned off during sympathetic nervous system. Adrenergic antagonists, we also call them sympatholytic drugs. They directly block alpha and beta adrenergic receptors on the tissue, resulting in a decrease of the sympathetic activity. So they might lower the cardiac output, lower blood pressure if we're blocking them. So for clinical application, when you guys are going to learn a lot about this in the local anesthetic class, but epinephrine is in a lot of our local anesthetics. And so how does that play a part with patients who have heart conditions or who take certain medications? So the epinephrine in local anesthetic that we give, it will stimulate both the alpha-1 and the beta-2 receptors on the smooth muscles. So it's going to stimulate both of them. However, it has more of an affinity for beta-2 receptors than for alpha-1. So what tends to happen is you might get a very initial spike in blood pressure, but then you end up getting an ultimate kind of lowering of blood pressure. So for hygienists, you may take your patient's blood pressure before you give them local anesthetic, and you may notice that when you take their blood pressure at the end of their scaling and root planing appointment, because a lot of times we use local anesthetic when we do scaling and root planing, their blood pressure might be lower than it was in the beginning. Well, a couple things. The anesthetic might have lowered their blood pressure a little bit if you only gave them 2 or 3 carpules. And also they're more relaxed because the scary event is over. So they might have lower blood pressure. Now, doctors need to think about this in a little bit different ways, because doctors have a tendency to give a lot more anesthetics. So if you give more than 3 or 4 carpules, you could actually end up causing a patient to have higher blood pressure, but usually hygienists don't give that much anesthetic. So as it says here, initial increase of blood pressure with alpha-1 stimulation, contraction of smooth muscles, but an ultimate drop in blood pressure due to beta-2 stimulation, relaxation of smooth muscles. The worksheet we're going to talk about a little bit more and probably start out next week with it. And then maybe also if you guys can come into one of my open times, we can talk about the worksheet as well. And I've posted the keys. And then this is just an exercise that I really recommend you to fill this out. Take flashcards and on one side write, what do alpha-1 adrenergic agonists do to the body? And then write it on the opposite side. What do alpha-2 adrenergic agonists do to the body? And then write it on the other side. And then maybe name some drugs. So like for instance, I wrote alpha-1 receptor. It's located on the smooth. So if I was to answer this, I'd put alpha-1 receptor on one side, and then on the back, I'd put located on smooth muscle, smooth muscle contraction, blood vessels, sweat glands, eyes, intestines. And then you want to write down, I didn't write down all the stuff. This isn't a good example. But then write down some of the things that, not just what happens in the body, but if you take a drug that will stimulate this, then what do you think might happen because of it? And then do the same thing for the alpha-1 and alpha-2 adrenergic blockers or antagonists. If it's an antagonist, it's a blocker. So if you're blocking alpha-1 and alpha-2, how's the body going to respond? If you are stimulating alpha-1 or beta-1, beta-2, what does it do to the body? If you're blocking beta-1, beta-2, what does it do to the body? And I'm going to make a table and post that kind of goes along with this study exercise. But I want you guys to do it first, and then I'll post a table next week, or maybe midweek. Maybe I'll do it before the end of the week. Okay? All right.